All right, I think we're going to go ahead and get started. Hello, everyone. My name is Tess Killian, and I'm so happy to welcome you to the 6th Annual Cannabis in Practice webinar series, hosted by the Washtenaw County Health Department and Livingston County Health Department in partnership with the Washtenaw County Medical Society. This webinar series is aimed at addressing questions our local and regional healthcare providers have about cannabis use and their patients. Our speakers come from a wide range of backgrounds and are experts in their respective fields. Funding for this series comes from the Michigan Department of Licensing and Regulatory Affairs Cannabis Regulatory Agency. This live webinar has been approved for one social work continuing education clock hour, one specific MCBAP credit hour, and 1 credit hour of CME. If you are requesting any of these continuing education credits, please be sure to stay until the end of the webinar to fill out our post-webinar evaluation survey. Please be sure to provide your name and email address to ensure that you receive certification for your attendance. This webinar is being recorded. The recording and presentation slides will be available on our website, washtenaw.org/marijuana, in the coming weeks. Before we get started, we ask that all questions for our speaker be asked through the Q&A function, which can be found at the bottom of your screen. We will have time at the end of the webinar for the speaker to answer questions. I am pleased to introduce today's speaker, Dr. Ken Finn. Kenneth Finn has been practicing pain medicine in Colorado Springs since 1994. He is board certified in physical medicine and rehabilitation, pain medicine, and pain management. He is certified in cannabis science through the University of Colorado. He is a volunteer clinical instructor for the University of Colorado Medical School, Colorado Springs branch. He is former president of the American Board of Pain Medicine and has served on their exam council for over 20 years. He served on the Colorado Governor's Task Force on Amendment Social Issues Work Group and served 4 years on Colorado's Medical Marijuana Scientific Advisory Council. He was an invited speaker to the United Nations Commission on Narcotic Drugs in Vienna and has testified to the Canadian Senate on their marijuana bill, as well as New York General Assembly, and speaks internationally on the health impacts of marijuana. He works nationally with other state legislators considering legalizing marijuana for medical and recreational purposes. He is an editor of Cannabis in Medicine, an evidence-based approach, and currently the co-vice president of the International Academy on the Science and Impacts of Cannabis, which is now a member of the Vienna NGO Committee on Drugs. And we're going to advance the slide to just give a statement on continuing education. So none of our presenters, none of the planners or speakers for this educational event have any relevant financial relationships with ineligible companies to disclose. And with that, I'm going to hand it over to Dr. Finn. We look forward to your presentation. Thank you.
Thank you. Can you hear me okay?
Yes.
All right. So we have a lot of ground to cover, so I want to be mindful of everybody's time, and I'm more than happy to answer any questions at the end of the presentation. So I'm going to start by a picture close to my house. This is a retail marijuana store very close to where my kids went to school, and you can see that the Girl Scouts were selling their wares outside the marijuana dispensary. So it kind of raises my concern on messaging to young girls on, this normalization of marijuana use. I actually wrote a letter to the Girl Scouts of America, and they didn't really care that these girls were selling. I think they were more concerned about how much money and cookies they were going to sell rather than the messaging that we're giving to these young children. I'm going to talk a little bit about the basic science of the cannabinoids. And you can see, and I'm not going to get too sciencey on this, I just want to kind of cover some basic stuff so people have a good understanding. These molecules are the natural delta-9 tetrahydrocannabinol, or THC, which most people are familiar with. The other one is cannabidiol, or CBD. And the other one is a synthetic THC, or dronabinol, that has been around for nearly 40 years. That's actually an FDA-approved cannabis-based medication. And so you can see they are very similar in their chemical molecular formula and makeup, but around the 7 o'clock position, there's something a little bit different, and that might explain why their mechanism of action or varies a little bit. But that's the answer, which one is the natural, the synthetic, and then the cannabidiol or CBD. If anybody's worked in pain, this is sometimes how you feel at the end of the day because it's a very challenging patient population to contend with. This is a very important slide to remember. And I'm going to highlight some slides as we go down the road here. There's a very significant difference between what is cannabis-based medication and medical cannabis. The medications are registered extracts. They have very defined and standardized content. Examples are the dronabinol that I mentioned, which is a semi-synthetic THC that is actually FDA approved for chemotherapy-associated nausea and vomiting, or weight loss and appetite stimulation in people with HIV and AIDS. Epidiolex is a natural CBD that's FDA approved for a very narrow spectrum of pediatric seizure, which I'm going to circle back to later. And the Sativex is not available in the United States. It's a natural, nearly one-to-one THC CBD mixture that is very defined dosing. Medical cannabis, on the other hand, are just plants, the plant material, the flowers, the buds, extracts, full plant extracts that are used for reported medical reasons. Unfortunately, they're very poorly regulated or tested for contaminants, which product integrity is a big platform of mine that I'm very concerned about. I've been following this data for many, many years. Because of COVID, I haven't been able to get any updated information since 2018, but the data has been fairly consistent. Why do people go to the doctor? They go for hypertension, obesity, asthma, diabetes, et cetera. But in the top 20 reasons across the country, knee pain is the only pain diagnosis in the top 20 reasons people see their doctor. Things that are not in the top 20 are things I would have expected as a pain physician, like back pain, neck pain, headache, neuropathy, but things like cancer, seizure, not in the top reasons people go see their doctor. I'm going to spend a little time on this relationship, and I circle back to this several times during the presentation about the tight relationship between the cannabinoid and opioid systems. They're very synergistic. The receptors belong to the same type of G protein coupled receptors. When they're activated, they do the same thing by reducing the intracellular levels of something called cyclic AMP, and by doing so, they modulate pain pathways. So the opioid and cannabinoid relationship is very, very tight and intricate. The receptors are both found on presynaptic terminals of the nerve endings. They co-localize in what are called GABAergic interneurons, which are the neurons or nerves that modulate pain pathways. And they do share pharmacologic profiles, which include anti-nociception or pain-relieving qualities. So there is, from a basic science perspective, evidence that cannabinoids may have some pain-relieving qualities because of the way they work at the basic science level. The other things that overlap with opioids are hypotension, decreased intestinal motility, drug reward, reinforcement, and actually naloxone, which is the antidote for opioid overdose, has been shown to have effects in the cannabinoid system in animal models. So there's a very tight, intricate relationship between opioids and cannabinoids is apparent. And we're in the middle of an opioid epidemic. Some people are calling it an overdose epidemic. And going back in time, the National Academies of Science, Engineering, and Medicine published a paper that there was substantial evidence that cannabis is an effective treatment for chronic pain. So I found that very interesting. So I read the paper in detail. The interesting thing is that they didn't really look at what people are using. They did not really look at dispensary cannabis. There were very few studies that looked at what people are using. The things that people are not using that they studied are, number one, things that are not available in the United States, the nabiximols like Sativex, or they looked at the synthetic cannabinoids, which a patient never has asked me for their pain problem. So the devil's in the details. So despite the fact that they had this conclusion, it really didn't look at what people were really using. And over time, you can see our drug crisis has worsened. This was a CDC data from a few months ago. This was a nice paper showing why people are turning to use of cannabis, and by far it's pain. That's what most is commonly recommended for the use of cannabis is pain. But pain is a very broad diagnosis. So under pain, you've got visceral pain, somatic pain, psychogenic pain, neuropathic pain, and under all those little umbrellas are other subcategories. So pain is a very broad diagnosis and very generic. Here in Colorado, and I haven't seen the more recent data, but in the year 2022, more than half of the medical marijuana recommendations were made by 10 providers, one of which made between 7,000 and 8,000 recommendations in a year. To me, this is almost reminiscent of the pill mills. And I'm going to interject right now, just as for future reference. I was a former registered medical marijuana patient in the state of Colorado. Full disclosure, I don't use. But based on my conversations with my patients, I wanted to know how easy was it to get a medical marijuana recommendation. And literally, I was approved in 60 seconds. There was no medical record review, no physical exam, no review of my MRIs because I've had multiple knee surgeries. And the recommending physician never asked me my level of pain for my knee arthritis, which fits with the ambulatory care data. On a day-to-day basis, about 0 to 2 on a 10 scale. It's effectively managed with ibuprofen or other anti-inflammatories. But I was approved for severe pain in 1 minute. And the person never asked me my level of pain. So it really underscores kind of the ruse in a lot of these medical programs. I think people may be medicinalizing recreational use, perhaps. But you can see that very few providers make recommendations in the state of Colorado. And one of the platforms to go down this road was it's going to help our drug crisis. Which is kind of interesting because going back to 2002, this is state data. In Colorado, we voted to legalize marijuana in the year 2000 and implemented it in 2001. With the knowing that the vast majority of people were getting recommended for pain, I think at this point, more than 80% of the marijuana recommendations are for severe pain. We're in the middle of a drug crisis, and they're saying, well, let's do this because it's make our drug problem better. And so going back in time, looking at 2002, shortly after we implemented, this is the overdose death rate in the state of Colorado. I live in El Paso County, kind of center-ish in the graph, about an hour south of Denver. And this is what happened in 2002, 2005, 2008, 2011, and 2014. It did not get better. It actually got much, much worse. Here's some of the graphics from the Colorado Department of Public Health and Environment. And going to the far left in 2000, that's when we implemented medical marijuana. And in 2001, we voted in 2000, implemented in 2001, and the program lay dormant for several years because there was no infrastructure. I mean, physicians were fearful to recommend for fear of litigation, losing their license. There were no dispensaries around, so it was kind of dead in the water for several years. But in 2009, we had for what I would call de facto legalization, when the dispensaries opened up to the point that even today we have more marijuana stores than Starbucks and McDonald's combined. And then we voted to legalize in 2012 and implemented that in 2014. And look what happened to our other drug deaths. We've had a significant rise in prescription opioids, methamphetamine, other stimulants like cocaine, and fentanyl was just starting to become a thing. And this is the 2019 data. There's the 2020 data. It actually looks like the COVID curve. And interestingly, heroin started to fall flat, as cheap and readily available as it is, and actually has been on the decline, which I'll get to in a sec. But our drug problem has significantly worsened. There's the 21 data. So they actually had to compress the graph because our drug deaths have gotten significantly worse. This is the 22 data, and I'm like, oh, maybe we're onto something here where the curve has started to flatten out. But you can see that heroin is way on the decline. I think fentanyl is now the new heroin. We have increased deaths related to stimulants like cocaine and methamphetamine. But look at the lowest graph, the green graph. These are mentions of cannabis in overdose deaths in the state of Colorado. I think Colorado is like the only state looking at this. So I give them a lot of credit for looking at this data. But unfortunately, 23 was another record. We broke another record of drug overdose deaths. A lot of it's likely contributed to fentanyl. But why are the cannabis mentions going up? I mean, more likely than not, they're companion drugs. But the coroners and medical examiners are not differentiating between synthetic THCs and the natural THC. Is it present? Because we do know that cannabis does have other health effects that could lead to death, which I'm going to get to later. In Michigan, you can see the deaths are on the rise. 23, it looks like you may have had a drop off. I mean, I don't know what happened in 2020. There would seem to be a drop in the curve, but I got an email. I emailed the state health department a couple of days ago, and they said they still don't have the final data for 2023. We're already way half through 2024, they still don't have the final data for 23. And you can see what happened in 2000, the opioids, and then the heroin, and then fentanyl, and then other, all these drugs play very well in the sandbox. In In Washington, D.C., you don't even need to have a supervising doctor to be called a, quote, patient. You can go to a kiosk in D.C., say, I have pain or headache or whatever, and you put your money in your credit card and out pops your card, you go to the medical dispensary. So you don't even have to have a physician supervision. So I don't even know why they're even called patients. But you can see the number of patients in D.C. skyrocketed after they got rid of the doctors, took them out of the picture. So the pendulum began to swing in the late 20-teens, early 2020s, where the data is starting to show that there really is no protective relationship between overdose deaths and medical cannabis laws. It kind of goes against the grain of what the public opinion is or what the mantra is that the mainstream media tends to report on. I actually published a paper with the help of primarily Dr. Archie Blyer, who's a pediatric radiation oncologist who was at MD Anderson for a while, but now he's in Oregon. Marijuana is supposed to help reduce our opioid mortality. But interestingly, the opioid deaths have increased more where marijuana was legalized, and particularly the fentanyl death rates. And here's the graphic to that. You can see all the states in green, red that have, both med and rec. But you can see the disparity between the non-legalizing and the legalizing states. There's a big gap in terms of fentanyl death rates. I mean, again, these drugs play very well in the sandbox together. This was followed up by a paper independently of ours showing that legal medical marijuana, particularly when available through dispensaries, there's higher opioid mortality. So it isn't helping our drug crisis. It's more likely than not contributing to our drug crisis. So before I shift gears, I want to talk a little bit more about this opioid cannabinoid relationship. So looking at the Youth Risk Behavior Survey data from a few years ago, the number one risk factor for an adolescent to misuse opioids is having ever used marijuana, lifetime use. I'm going to circle back to this point a little later on the slide, but the number one reason why a kid may misuse opioids is if they've ever used marijuana. And they looked at other co-founding factors as well. There was a nice paper from Wadaker from the Midwest. He was actually a high school student. It was a very interesting paper that he used a very interesting matrix, but the predominant predictor for an adult to misuse opioids was having ever used marijuana before the age of 18. So this is a very interesting, again, this relationship between cannabinoids and opioids. This JAMA Pediatrics article that came out, and I was very surprised about this. After 3 years of first trying marijuana compared to opioids, marijuana has a much higher percentage of addiction in the adolescent, partly related to the developing brain issue. And this is the graphic from that. So I'm going to stop and kind of look at this in detail. This is from that paper from JAMA Pediatrics. So if you look at the early onset users, these are a very vulnerable population, ages 12 to 17. Line 1 and 3, cannabis compared to opioids about a year after, they have a very similar addiction rate of about 11%. 3 years later, those early onset users have a very static or stable opioid addiction rate of about 11%, but the cannabis early onset users have nearly double the addiction rate, about 20%. Fascinating. I'm a pain doctor. I did not expect this at all. If you look at the later onset users, line 2 and 4, they also have a very similar addiction rate about a year later, 6.5%, 7%, lower than the early onset users. And 3 years later, the opioid later onset users had a very stable addiction rate of about 7%, but the cannabis later onset users still had a higher percentage of addiction, still lower than the early onset users. So I think the take home from this is two. One, cannabis seems to have a much higher addiction potential in the early onset users more than opioids. So the delay onset of use is very important to counsel our youth on. This came out a few months ago. If you look at other confounders, lifetime recreational marijuana use compared to no use at all was associated with a higher odds of daily prescription opioid use. So again, this kind of fits with Wadaker's paper showing that, having used marijuana in the past might be a predictive factor, one of many, of opioid misuse. So in summary, before I move on to other things, regarding cannabis and opioids, there's no accepted evidence that dispensary cannabis helps for chronic non-cancer pain. And actually, I gave a presentation to MD Anderson Cancer Center about a month or so ago, showing that even in the cancer patient population, adding cannabis to opioids doesn't improve patients with chronic cancer pain. There's no accepted evidence for substituting opioids with dispensary cannabis because there's no package insert. I mean, if you look at dronabinol, which is a synthetic THC, there's a package insert, and actually there's warnings on psychosis, overdose, et cetera, in the FDA-approved cannabis-based medication, which I do support. Cannabis users are more likely to develop opioid use disorder, misuse their opioids, have other negative psychiatric effects, and states with medical marijuana programs typically have higher opioid deaths than non-medical states. So even this, despite the fact that from a basic science perspective, there is evidence that it may provide some pain relieving qualities. There's other data showing it's no better than placebo, but the scientific says, yeah, there's analgesic properties, but it really is currently outstripped by the current body of data. The brain is the #1 target organ. I want to talk a little bit about the brain. This was a nice paper, a longitudinal study looking at over 1,000 people from New Zealand, going back to the 1970s, followed to the age of 45, and they had a 94% retention rate, which is pretty amazing in this day and age to have that many people stay with this type of study. And they showed that long-term cannabis users showed a decline in their IQ of about 5.5 points. They have difficulty learning, processing speed relative to their childhood IQ. And if anybody's old enough to remember, they removed lead from lead-based paint because it dropped IQ by about 4 points. I don't know why this does not get more attention, but it doesn't. But that's why I do what I do. Long-term cannabis users have smaller areas of the brain called the hippocampus, which modulates memory. So there's actually physical changes in the brain with chronic use over time. Marijuana is addictive. This is kind of following the same playbook as big tobacco. If anybody remembers the tobacco hearings, the congressional hearings, they went down the line with the tobacco company saying that nicotine's not addicting, although we do know it is. This is following the same playbook. Several years ago, again, recent data shows marijuana has about a 30% addiction rate. Historically, in the past, it was about 9% in the adult and about 18% in the adolescent addiction rate. But now with the expansion of these products that are maybe more potent, the addiction rate now is about 30%, which is pretty scary, 1 in 3. Looking at cannabis use disorder last year, looking at the states that had legalization, and this is in the VA healthcare system, which I think is a great system because they can kind of keep things controlled to a certain degree. But medical and recreational cannabis law enactment showed a significant role in the increases of the cannabis use disorder prevalence, particularly in the older population. There are other factors, but it's important that we screen people, particularly veterans, for their cannabis use. This came out just a couple of months ago as well. Managing chronic pain with medical cannabis had a higher risk of developing cannabis use disorder. Again, very similar percentages, about 30%. So almost 1 in 3 person, 1 in 3, 1 in 4 persons using cannabis may become addicted to it. The brain and the schizophrenic link is there. This came out about a year ago from Denmark. One of our advisors at Isaac is one of the primary investigator in this particular study. They looked at 6 million people in Denmark over 50 years. That's a big, huge, long study. And they guessed that up to 30% of the cases of schizophrenia among men may have been prevented if they averted cannabis use disorder. So there is a very strong association between cannabis use and psychosis, which I'm going to get to, and schizophrenia is on that spectrum of psychoses. It's a persistent psychosis. And the healthcare costs related to schizophrenia are huge. Interestingly, it didn't affect women as much. It seemed to be more prevalent in the men, and that's the graphic, men to women. So this transition of schizophrenic spectrum disorders in the emergency department, this came out about a year or so ago, just almost a year ago, looking at all substance-induced psychoses. I mean, because people can become psychotic even on nicotine or caffeine or alcohol, but there was a higher risk of developing schizophrenia spectrum disorder with other substance-induced psychoses, but cannabis had the highest transition risk among visits with psychosis, and the third highest risk in those without psychosis. So even the Colorado Department of Public Health and Environment released a paper showing that, especially in the youth, which I think are a more vulnerable population, frequent use is associated with psychotic disorders, including schizophrenia. So our public health department knows about this. So why are mainstream media not educating our youth in this risk of psychoses, including schizophrenia? This came out just a couple months ago. psychotic experiences following use of high potency cannabis. I mean, the European data shows that if you're using products higher than 10% THC, you have a nearly five-fold increased risk of developing psychosis. That doesn't exist in the US. I mean, we have products that are, the flower is about 30%, concentrates are 60%, and then the dabs, waxes, shatters are, through the roof, 85, 90, some claiming 100% THC. So you have a higher risk, particularly in these vulnerable brain populations, of developing psychotic experiences. And that's kind of the graphic from that. Looking at self-reported cannabis use in the US, this came out just a couple months ago, looking at the increase of use during time. I mean, it kind of fits with, more access, social norming. If you say, well, it's safe, it's herbal, it's medicinal, more people are likely to use, and then you have use rates go up. And actually, this cannabis consumers now exceed the alcohol users when you're talking about daily or near daily use. There's more people using marijuana daily or near daily compared to alcohol that are using daily or near daily. The heart is the second target organ when you're talking about cannabinoids. And a lot of people don't know this or don't talk about it, but one of my authors, Robert Page, he's a pharmacist from the University of Colorado who helped contribute to my drug-drug interaction chapter, was the lead author on the American Heart Association paper that came out a few years ago, looking at the risk of heart attack, stroke, sudden death, and arrhythmia when you activate the CB1 receptor. So I think that people don't really understand that there's a cardiovascular risk and a cerebrovascular risk when you're using cannabis. Looking at some of the other papers over time, medical cannabis users, again, not just recreational, medical cannabis users have a higher risk of heart rhythm disorders compared to non-users. They have a higher, what's called SVT, or supraventricular tachycardia, PACs per hour, more non-sustained VTAC. So there's rhythm problems associated with cannabis use. This came out from the American College of Cardiology. People who use marijuana daily were found to be at 1/3 more likely to develop coronary artery disease. And this was interesting paper because this is not in the older population like myself. These are in the young people in the 30s and 40s that are developing coronary artery disease compared to the ones that are not using cannabis. I find it very interesting. Looking at recreational drugs with acute cardiovascular events in the hospital, people use all sorts of stuff and they can end up in the hospital with an adverse event. Recreational drugs, had a higher rate of in-hospital adverse events, but cannabis seemed to be the most prevalent compared to opioids or cocaine or amphetamines. I mean, look at almost 10%, 10% of people that have an adverse event were positive for cannabis rather than the other things that people would suspect. Adults with cannabis use disorder have a higher risk of incident adverse cardiovascular disease events than those without a cannabis use disorder. Again, the heart is the second target organ. Just several months ago, the Journal of the American Heart Association came out with another paper because a lot of people that smoke marijuana smoke tobacco. So it's hard to tease them apart and say, well, is it one, A, B, or both? But they actually did tease it apart. Among never tobacco smokers, daily cannabis use was associated with higher heart attack, stroke, coronary heart disease, et cetera. I'm going to talk a little bit, I'm going to shift gears again, because again, there's a lot of ground to cover. These are some vulnerable patient populations that I'm very concerned about. I'm going to talk about the in utero data. This is very frightening, and I think if marijuana was actually a medicine and had this impact, it would be pulled off the shelves. So this is the SAMHSA data from January of last year, looking at the near daily cannabis use by pregnancy trimester. And you can see the blue line, the near daily use over time, going back to 2002-06, has skyrocketed. During total pregnancy, there was kind of a dip to 2015, but then really jumped up throughout total pregnancy. But even in the third trimester, it kind of drops off. But the first and second trimester, the women are using more often, almost near daily. And that's very concerning because that is a very critical period of time for development of the brain and other organs. This is a data point number one I want to get to. In Colorado, more than 70% of the dispensaries that were surveyed told women to use during the first trimester. To me, it's practicing medicine without a license, but the state won't do anything about it. And we know that THC persists in breast milk for up to 6 weeks. And we know that there's impacts on executive functioning and thinking even into young adulthood. This is based on a functional MRI study done many years ago. There was over 400 dispensaries surveyed, and more than 70% told women, yeah, you need to use marijuana for your nausea. Data point number 2, a lot of states don't look at this information. I would recommend any state that has any medical recreational program, look at this. I think Colorado and only 1 or 2 other states I've worked with track this. But Connecticut looked at substance exposures in infants. And over a 28-month period, there was about 4,700 notifications. That's about 6.6 babies a day were exposed to a substance. Nearly 80% of them were marijuana, followed by the usual suspects, much lower, 20% for opioid, less than 3% for alcohol exposure, but a significant amount of marijuana exposures over time. This is a very important study. It's an ongoing, it has different arms to it, but the ABCD study, I'd recommend people look it up. It started many years ago, but what happens to those kids when they're exposed in utero? And this is kids ages 9 to 11, so middle childhood. So looking at cannabis exposure only, not other stuff, before and after the mother knew of the pregnancy, those offspring had more psychopathology characteristics and then problems with attention, thought, social problems. And more concerning to me, these kids are developing psychotic-like experiences, even though they're not using. So I did a PubMed search looking, are there psychotic-like experiences associated with exposure to heroin or cocaine or methamphetamine or alcohol, nicotine, whatever? And I couldn't find it. It seems very unique to cannabis exposures. So prenatal cannabis exposure, higher risk of psychopathology during middle childhood. This went on looking at nearly 12,000 kids. This came out of NIDA, National Institute of Health, looking at attention, behavior problems, and that persists when those kids get even older into early adolescence. So the exposure in utero has long-term implications. They've continued to look at this. Prenatal cannabis exposure, higher risk for cannabis initiation. So early onset use. Remember what we talked about, this whole cannabinoid opioid connection. But the number 1 risk factor for a kid to start early was having been exposed in utero. I find this very fascinating. And they looked at other things, alcohol, tobacco, family problems. And here's the graphic for that. So these are all the things that they looked at when kids start early initiation. And you look at all the things they looked at. And the very number 1 at the very top, prenatal cannabis exposure by far outnumbers all these other things, these other factors. So this is like a circle thing. In utero exposure may put you at risk for early onset use. Early onset use, we know there's problems. Perinatal health research last year, because they blame the mom on a lot of things. Well, bad mom, you smoke cigarettes or you're drinking alcohol when you're pregnant. But there's data that paternal use can adversely affect reproductive health and offspring outcomes, including lower birth weight, spontaneous abortion, and SIDS. There's the THC induces placental and DNA, what's called methylation problems in genes for autism spectrum disorders. So it's not just the mom. And I think Canada, the country of Canada, in their public health department, they recommend that young men, if they're interested in starting a family, do not use marijuana because of these things. There have been papers published over time showing that the U.S. has a more than 20% higher incidence of autism spectrum disorders in medical marijuana states. So this is a public health concern from my perspective. Here's the graphic from that particular paper. A few months ago, looking at ADHD symptoms and autism spectrum associated with in utero cannabis exposure compared to the non-exposed counterparts. I mean, this is a very large study of over 200,000 participants. So it may increase the risk of ADHD or autism spectrum disorders in both maternal and paternal use, the mom and dad that may be using. So even if the mom is completely clean as a whistle and dad is a daily user, you still may have a bad outcome or an adverse event with a child. Looking at from the in utero infant to the pediatric data, our kids are getting poisoned. This came out of Facebook from several years ago. This just sends a very scary message to me and probably to most people. Looking at the number of poisonings over time in Colorado, in the 0 to 5 age group, much less than the older age group. And looking at the American Academy of Pediatrics, there was a 1,300% increase of child poisonings over time between 17 and 2021. And a lot of these kids that they don't metabolize cannabis like an adult. They may have central nervous system depression, and nearly 23% of these kids end up in the hospital. There's the graphic from that paper. Looking at a separate paper, looking at 52 children's hospitals across the country in the Pediatric Health Information System database between 2004 and 2018, similar data, 1,300% increase of kids exposed in 2018 compared to 2004. 50% end up being in the hospital, 15% required ICU care, and 4% ended up on a ventilator. Again, these kids are much higher risk for an adverse event, typically a neurologic event. In Canada, and this is a very interesting paper. I would recommend if anybody's interested to read it. This is their pediatric poisoning data. What's going on in Quebec? You know, they have a flatter curve on pediatric exposures, but in Quebec, what happened around 2019 is they banned edibles. And you can see that the number of kids getting poisoned flattened out. I mean, a little bit of a rise, but compared to the other provinces like Ontario, Alberta, BC, Quebec has a flatter curve because they don't have edibles. They banned them. Again, this came out a few months ago, looking at youth in children's hospitals across the country. All substances except sedatives had an increase in growth and visits, but cannabis had the largest percentage of visits, nearly over half of them, and the greatest percentage of growth. There's the graphic from that paper. You can see kids get their hands on all sorts of stuff. The alcohol, opioids, hallucinogens, which interestingly had a spike in 2020 and then dropped off, nicotine, et cetera. But look, the top right, cannabis is steady and strong and on the rise, and is accounting for a lot of our kids ending up in the hospital. Looking at misuse ingestions in school-age kids, a 245% increase since 2000, while alcohol abusers steady decline over time. I think part of this is the messaging we're giving kids, social media, it's safe, it's herbal, it's medicine, or what have you. And so they're going to use it more because that's the message that they're getting. In Michigan, there were 3 students who were 12 years old. One was 11, hospitalized, eating marijuana gummies. This came out just a month or 2 ago. Students were experiencing major effects. They had difficulty walking, tachycardia, high heart rate. We talked about the cardiovascular effects. They were sluggish. And it wasn't the first time it happened in the elementary school. There were more children getting ingestion edibles, going to the hospital, Michigan Poison and Drug Information Center. 801 incidents in cannabis toxicity among kids 5 and younger in those couple of years. I mean, so their kids are getting their hands on stuff and having difficulty. This paper showed a 75% increase of unintentional youth cannabis ingestion in 2 years for those under the ages of 5. Unintentional cannabis use by kids 4 to 13 grew by 60% between 2020 and 2023. And central nervous system depression. Again, the brain is a target organ. Sleepy, confused, parents had to carry them into the waiting room. Respiratory function can become compromised, although from a basic science perspective, the receptors aren't in the brainstem where the breathing center is. So people typically don't overdose and die from this. They stop breathing when they use marijuana, but in children, that can happen. Getting to the older population, adolescents, this is a very important slide to note. Again, I'm going to highlight several of them. Kids that have cannabis use disorder is a small percent. I mean, not every kid that uses become addicted, although it does have, nearly 30% addictive right now because of the potency. But the kids that don't have a problem, they don't have a use disorder. It's called non-disordered use. That's about 4 times as prevalent as past year cannabis use disorder. So there's much higher number and volume of kids that are using cannabis that don't have a use disorder. So it's a bigger number. But those kids that have non-disordered use have 2 to 4 times higher odds of all adverse psychosocial events, including depression, suicidal ideation, thinking problems, lower GPA, aggression and violence. And I don't have time to get into some of those things, but yeah, violence is a big problem. Looking at in the Journal of Preventive Medicine, The association between depression and cannabis use is there. We know, if it chills you out or makes you relax, but there's other negative psychiatric effects, including depression, suicidal ideation, et cetera. This paper is interesting. The American Academy of Pediatrics, adolescent prescription opioid misuse, higher odds of suicide-related behaviors. And I actually had a conversation by email with the author, and I said, did you look at marijuana? They said, no. We just said, kids that use opioids or misuse opioids have a higher risk of suicidal-related behaviors. Do you remember what I mentioned earlier? I told you I'd circle back to this. The number one risk factor for an adolescent to misuse opioids was lifetime use of marijuana. So is this kind of another pathway to suicidality by starting with marijuana, developing opioid misuse, and then progressing based on this paper from opioid misuse to suicidality? But we know the depression and suicidality are there in the adolescent population. Higher odds of depression, severity, suicide attempt. Here in Colorado, and again, a lot of states are not following this. And Colorado, I believe, has a mandate in completed suicide of drug testing in adolescents. So now the most recent data that I was able to find that in 2021, that nearly 43% of adolescents that complete suicide are positive for marijuana. It never used to be that way. I've been tracking this data for many, many years. It used to be alcohol, and then it flipped in 2012. Interestingly and coincidentally, when we voted to legalize, marijuana became the number one substance found in completed teen suicide. And now the number two, that used to be number one, is alcohol. And look at it's from 43% to 27%. So a significant difference between number one and number two that's present on toxicology. And you can see on the left-hand side, there's all these other factors with mental health, depressed mood, suicide note, et cetera. So our kids, I wouldn't want to be a kid these days. I mean, there's so much pressure with social media. I mean, our mental health crisis is multifactorial, but nobody talks about the marijuana link. And actually, in the state of Colorado, if you look at toxicology among people under the age of 25 in the state of Colorado, 30% there's nothing there, but 31% of the time marijuana is there, compared to number two, again, alcohol, and then the other usual suspects, carbon monoxide, opioids, which is number four if you include no substance, but significantly less than THC presence. So I think the THC is doing something to the brain and maybe leading down this pathway of depression, anxiety, suicidal ideation, and completion. This came out with looking at these kids over time again, from those that are under the age of 25, what happened with retail, fentanyl epidemic, and the COVID pandemic. You can see that THC only is kind of static, but THC plus other is on the rise. And actually, some of these kids had only THC present end of 226. So looking at age-dependent cannabis use with risk of psychosis, and this came out just a month or so ago, especially in this vulnerable population, these kids, these adolescents and teenagers, now 11-time higher risk of developing psychosis. 5 out of 6 teens with psychotic symptoms had used cannabis. So there's a very strong relationship between cannabis use and psychosis and other mental health issues. Could be in part related to potency. In Canada, they had papers showing that prevalence of cannabis use among 16 and 19 years of age, high increase about 36% to 43%. So more trouble in Canada as well with their youth using. How is non-medical cannabis legalization serve and welfare of the underage youth in Canada? This also came out a couple of months ago, a 20% increase equivalent for emergency department visits that involved cannabis-related disorders or poisonings, hospitalizations, et cetera. I'm going to shift gears to another population, the older population, which is kind of underrepresented in the medical literature. But the state of California, this paper came out about a year and a half ago, the number of emergency department visit rates increased by 1,800% over time, which is between 2005 and 2019. So California was kind of the lead of the pack. They had medical marijuana back in 1996, and now with promotion, commercialization, expansion, normalization, now the older population are maybe paying the price. I mean, if there's more doctors recommending, and older people end up in the emergency department. And by definition, early elderly is 65 to 74, late elderly is 75 plus. That's the graphic. You can see the number of older people in the ED has significantly gone on the rise. In Colorado, this is just hospitalizations in general. And this came out earlier this year, but they're behind. They're tracking data. They're about 2 years behind. There were about 476,000 hospital discharges in the year 2022. There were about 12,000 that had a cannabis code, and of those, 7,100 had a cannabis-only code in the year 2022. So 58% of hospital discharges that had any cannabis code were cannabis only. That equates to 21 cannabis-only hospitalizations in the state of Colorado every single day. That, to me, is frightening. And a lot of states aren't looking at this. And I would encourage public health departments start looking at this very critically because that's been on the rise for sure. Another one of my platforms is product integrity. Just last year, Colorado was inflating potency. So what's in the bottle may not be what's on the label. 70% of the samples that they looked at had more than 50% lower than the potency numbers reported on the label. 3 samples had only half of the reported maximum potency. The state of Oregon, a lot of states haven't done this. I've requested our state to do this again, introspectively look at their programs. In 2019, the state of Oregon looked at their marijuana program, and they concluded that the testing program cannot ensure that the test results were reliable or products were safe for human consumption. I mean, to me, again, if any other medication failed this miserably, it would be taken off the shelves. And they only inspected 3% of stores for compliance. That's a huge fail. And they only looked at 1/3 of growers as well. So we're not doing a good job at regulating and managing these programs across the country. California has an 18% fail rate. And now we have these isomers and analogs, the Delta 8s, the Delta 10s, THCOs, which I'm going to get to. You can see the Delta 8 compared to Delta 9. And Delta 8 THC comes from federally legal hemp. For those that may not know, they mass produce CBD from hemp, and they manipulate the molecule because the CBD, Delta 8, Delta 9 have the same molecular formula. It's just how they manipulate the molecule and where the bonds are. You see Delta 8 where the bond is compared to Delta 9. But the Delta 8 comes from federally legal hemp. It's a side door, back door to mass produce THC products when they're not supposed to. You look at adolescents and Delta 8 THC and marijuana use, there was a significant rise in the number of students using Delta 8, typically getting them in states that don't have legalization. Delta 8 sold in retail outlets do not come from cannabis plants, but rather processed from hemp-derived CBD, like I mentioned. But if you're using Delta 8, you can still get the intoxication, impaired coordination, lethargy, etc. And THCO, which is not a natural molecule, that is created from Delta 8 THC that comes from CBD, that comes from federally legal hemp. It's 3 times stronger than the conventional THC. It was actually weaponized by the U.S. military in the 1940s as a chemical warfare agent because it eroded dogs' muscle coordination twice as much as conventional Delta 9 THC. There's links to those papers. The industry knew exactly what was going to happen when they passed the Farm Bill, and they knew exactly what they were going to do. 50% of hemp Delta 9 products are mislabeled. They get you higher than cannabis. Again, product integrity is very concerning to me. Here's a Charlotte's Web hemp product sold in Colorado, Evergreen, Colorado. They're very expensive, age restricted, 21 years or older, and there's nothing on the label. I mean, it doesn't say how much CBD is in there. Is there any THC in this bottle? I don't know. And it's about the equivalent of a cap of NyQuil. So it's about 30 cc's. You can take 1 cc a day. It's supposed to last you a month. But, if you think of a NyQuil, you can shoot that in a heartbeat. But I got the certificate of analysis of that little capful of NyQuil. And you can see second from the bottom line, there was 84 milligrams of THC in that bottle that had nothing on the label. So if an older person says, oh, I don't want THC, I'm just going to get this hemp product because everybody says it's wonderful and natural and doesn't have THC in it. Well, they can get severely impaired with 84 milligrams of THC in that one little bottle. Looking at CBD in particular, this came out from SAMHSA, looking at contaminants that including psychoactive THC. There's no evidence to support these false medical claims. We know there's liver toxicity, reproductive and developmental effects. But nobody's putting all these things together. And CBD, as I mentioned, in the formulation of Epidiolex, is FDA approved for a very narrow spectrum of pediatric seizures, Lennox-Gastaut, Dravet syndrome, tuberous sclerosis. And the authors, the people that got that fast track from Alabama through the FDA, wrote my chapter in seizure in my book because it's very interesting because there's evidence that it may be helpful for seizure, but that's with the cannabis-based medicine, not medical cannabis, because the medical cannabis stuff may have all these problems. And if you go to the Epidiolex website and you look at warnings and precautions, you will see things like liver damage, suicidality, sedation, and somnolence. So even though it may not be considered psychoactive, it certainly has its bag of problems. And most people don't realize that CBD has nearly 600 drug interactions. So I actually go with my patients to drugs.com. I said, you want to take CBD, Mrs. Smith, but you're taking ibuprofen. And you look at the drug interaction between CBD and ibuprofen, and there's a moderate interaction may cause liver damage. And people don't see this. CBD can result in developmental and reproductive toxicity, liver toxicity, drug-drug interactions. So there are safety concerns in patients and people that may be trying to consume CBD. Here's a patient of mine that tried CBD oil and got suicidal, which kind of fits with the package insert of Epidiolex. Looking at the content of commercial products, this came out just a month or so ago in a journal called Phytomedicine. Of the products tested, some of them had no CBD in it at all, and only 7.5% had accurate labeling. So again, a very huge fail in the commercially available products. Looking at the concentrates, it's funny and scary at the same time. This came from the CDPHE, looking at regulated concentrate. And you look at that little dot is a serving size when you're dabbing. I'm like, no one's going to just do that. I mean, that's like nothing. So it's very concerning that, even the state's trying to put some guardrails on these concentrates. Nobody knows that that's the size of a serving, is a little dot in the center lower right of the screen. We've had recalls with arsenic, cadmium, which is a heavy metal, yeast and mold, fungus. Here's a laundry list of the recalls from last year, more than one a month. And people don't talk about this. I don't know if everybody remembers a few months ago, the lead in baby food was a big scare. They took the baby food off the market because there's lead in there. Oh my goodness, it's not good for the baby's brain, et cetera. But looking at marijuana users, regular users, they have a higher level of lead in blood and urine. They have higher levels of the other heavy metals like cadmium in their blood and urine. And we know that lead can lead to heavy metal poisoning. But how come this isn't getting any attention at all? Here's the recalls in Colorado over time. Again, product integrity is a very big concern of mine. I mean, if you're going to treat it as medicine, treat it as medicine and put it through the rigors of study. In California, the lab director was caught faking the test results of 1/3 of the pesticides he was required to test under law. So there's recalls. A lot of those products are already consumed. In Nevada, there was inaccurate labeling, mislabeling of potency. They're inflating potency because they're going to get more money. Looking at the increases of THC concentration, the adverse health effects we know, and the problems that people can go down or develop if they don't know what's in the bottle and the label is not the same. Here's the graphic showing that, I can understand why Seattle would have more Starbucks than marijuana retail stores or McDonald's. But if you look at Denver and Portland, we certainly have more retail marijuana than Starbucks and McDonald's and even Colorado combined. Is it a cash cow? Here's the tax revenue in Colorado in the millions. It's starting to be on the decline. Maybe it's seen past its prime, perhaps. The black market is alive and well. The tax structure is very complicated, and or people just turning more to the black market because of who knows. But it's not solving budgetary woes. It's usually less than 1% of the state's budgets in every state that has programs like this. So I published a paper about having these discussions with your patients because it needs to be treated like any other centrally acting substance. I don't believe in co-prescribing opioids and benzodiazepines because of the risk of overdose, but I don't recommend patients are using opioids and cannabinoids because of the centrally acting effects. And, because there's no standard of care in marijuana world. And it's actually part of the reason was to kind of help providers, avoid litigation. I mean, you have to educate your patients on this. So if you tell, oh yeah, you have heart disease, it's great for your heart, go smoke a couple bowls, and then they get a heart attack, you're going to get in a lot of trouble. So in summary, before I open a Q&A, cannabis is not a medicine, it's a plant. We have a lot of plant-based medications already. I mean, aspirin comes from the bark of the willow tree. People will look at me sideways if I say, I want to plant a Pacific yew tree so I can get Taxol from it, because that's where Taxol, the treatment for breast cancer, comes from the Pacific yew tree. They say, well, you can't do that. That's not medicine. But why is cannabis getting a free pass? I 100% support the drug development process for cannabinoids, including dosing guidelines. Give me a cannabis-based medication like dronabinol or Epidiolex. Sativex is not available in the US, but give me something that's met the muster of scientific rigor, and I support 100%. As long as we know what the risks and benefits are. I think we should support a potency cap. I say 10%. People think that's too low. But, Quebec has a 30%, I think. Vermont has it restricted to 30% as well, which I still think is too high. Home grows are simply breeding grounds for illegal activity. We don't have time to get into what I know about the black market. We have to monitor public health impacts. I mean, I published a paper several years ago that between 09 and 14, one hospital in my town lost $20 million just for marijuana-related healthcare costs. And hypothetically, that's a $500 million price tag for the state of Colorado in those 6 years. That's about $83 million a year. So if you start, if you look at, I think our state leaders sometimes can't spell P&L or profit and loss. They always talk about the profit. They never talk about the loss. I mean, the legal drugs we already have, alcohol, tobacco, opioids, we know make a lot of money for the respective industries, but look at the healthcare implications of all of those, quote, legal drugs we already have. And now we're just adding another addiction for profit industry on top of it. And everybody thinks it's going to be all, rainbows and unicorns, but we know there's going to be public health implications. And publish the environmental impacts. I don't have time to get into this. I mean, Michigan's very rural. I'm sure it's being grown on the farms and maybe in the UP, who knows? But I'm sure it's there. And it's taxing our law enforcement. Mandatory drug testing for all violent crimes, because cannabis psychosis is real. We didn't have enough time to get into that. Protect your kids and their brains. I mean, I'm sad to say that education needs to start in the elementary school. I mean, I worked with a lot of my schools locally, and they're finding kids in second and third grades. So you're looking at 7, 8-year-old kids opening a lunch pail, and it's reeks of weed, and inside is an uncleaned marijuana container that has candy in it. And by law, the school resource officers cannot confiscate. But they suspect that mom and dad may be self-diagnosing Johnny and Sally's ADHD with edibles, because Johnny and Sally fall asleep after lunch every single day and don't learn anything. I remind people we're in the middle of a vaping epidemic before COVID hit. Combustion and inhalation and smoking is just not a good health choice in my mind, and not a good delivery system for medicine. You should do toxicology on all suicides. And I think there should be, again, as noted, mandatory testing for all violent crimes. I think it was McCrae from Michigan. I think he shot a few people several years ago. When I have his toxicology, he only had one thing in his system, was THC. Our roads are becoming less safe. This is what I like to do before I go to work. It kind of gets me centered and ready for a day. So I'm going to stop there and open it to questions. I know it's drinking from a fire hose, and there's just a lot to cover.
Yes, it definitely is. Thank you so much for that presentation, Dr. Finn. It was jam-packed full of data. So I really appreciate you coming today and speaking with us. We're going to open the Q&A. We'll have time to answer maybe 2 questions here. But while you guys type in your questions in the Q&A feature, I did want to share a couple reminders. So first is that the recording and the presentation slides will be available on our website, which is washtenaw.org/marijuana, in the coming weeks. And I also wanted to remind everyone that this live webinar has been approved for 1 social work continuing education clock hour, one specific McBAP credit hour, and 1 credit hour of CME. If you're requesting any of these continuing education credits, please fill out the evaluation form with your name and email address and follow the instructions that are specific to the credit type you are requesting. If you're unable to access the feedback survey that is in the chat, we will also be sending an email with the link to the survey to all webinar attendees later today. All right, so we did have a couple questions come in through the chat. There were two actually that related to route of administration or how people are using cannabis. One asked, were the studies that you cited in your presentation mostly focused on those who smoked marijuana, or did it include those using other routes of administration?
Most of the studies were smoked marijuana, and that's what most of the people are using, either joints, bowls, dabs, waxes, shatter, inhalation. But it does apply. I mean, the edibles and the other routes of administration can have the similar effects. And that's the problem with the edibles, is that the effects are delayed. Because you have to have first pass metabolism through the liver, so people will eat it's scary because you get a cookie, right? And the cookie may have 100 milligrams of THC in it. So they say take 1/6 of a chocolate chip. I can't eat 1/6 of a cookie. There's no way. But there was a perfect example. There was a man by the name of Levi Tamba, who was a exchange student from Africa, went to Wyoming, but came to Colorado and bought a cookie. He's not from Colorado. He got a medical marijuana product. He ate a little piece. He didn't feel anything, ate another piece, didn't feel anything, and ended up consuming the cookie. And then it hit him. And then he became acutely psychotic and jumped out a window and died. So, I mean, there's so many of these tragic stories with the edibles because the delay onset of effect. And not everybody that uses marijuana becomes a psychotic or homicidal maniac. But my point is that they're dancing in the raindrop. There's no good predictors on who's going to be impacted and who's not going to be impacted. I mean, I know people that use and they're fine, or they say they're fine, or they appear to be fine, but they're dancing in the raindrops because you just don't know who's going to have a problem. But a lot of these products vast majority of studies are smoked because that's what most people are using.
And kind of related to that, there was another question that asked if there's any differences in psychiatric and cardiac problems based on how cannabis is consumed.
Yes and no. I think with the smoking, the onset is a lot quicker. So historically, the onset of effect is within 30 seconds, peaks in about an hour, and then plateaus after about 4 to 6 hours. So you can have the development of tachycardia, paranoia, panic quicker with the inhalation because it gets into the bloodstream and into the brain quicker. The edibles can have the same impacts, but just a delayed onset of use. The onset might be 30 to 45 minutes and it peaks in an hour or two, and it's actually in your system much longer than the inhaled delivery system. But they have things like tampons and rectal suppositories. Any way to get it into the body, the industry has created it.
And someone was wondering about treatment for marijuana addiction. They asked if there are any medical interventions being studied to assist people with marijuana addiction.
We're in the middle of a mental health crisis, which is multifactorial. And the mental health treatment is poor across the country. So access is poor, treatment is poor, and there really are no good areas that I'm aware of that have in place. What happens when you are out in recovery? Do you just end up in the same environment and then have recidivism or there's no long-term treatment? But for example, one of my colleagues in Denver runs one of the adolescent substance treatment programs up there. And I ask him, I ping him every now and then. I go, what % of kids that you treat are there for cannabis use disorder? And every year it's very similar. And he tells me 97% of the kids that he's treating are cannabis use disorder. I mean, because kids do use a lot of other stuff. They use illicit substances and opioids, but the vast majority of our kids now are ending up with trouble with cannabis. And I think part of it's because of social norming. and increase access to use. And ease of access. I mean, you don't have to be 21 to get a medical marijuana card. You can still be in high school and just like me, a minute to win it, and I got it, and then I can become the school drug dealer, and that happens.
And one last question. You talked about how there might be THC in products that are marketed as hemp derived. This person asks, can we count on the COA to tell us the truth?
You know, I'm not sure. I mean, I would hope so. I think if you get the certificate of analysis, but who's doing that? I mean, who goes to the store and looks at the QR code and looks it up just to make sure? I bet that happens almost never. It may happen if people are concerned or have questions about the COA. You can get the product, and there's usually a QR code, and you can take the picture or get to the website, and it should tell you. But I can tell you, I don't do that for, my milk or any medicine that I get. I mean, I'm not worried about, my getting, Celebrex from my pharmacist if there's anything accurate about that. That's why I think if you're going to treat cannabis as medicine, treat it as medicine, make sure that it's not contaminated. But these products are contaminated. I mean, there was a cancer patient in California that died because his medical marijuana product was contaminated with a fungus. And the cancer didn't kill this person that was very treatable cancer. The fungal infection he couldn't fight while he was going through his cancer treatment killed the patient from his medical marijuana product. That's one of my biggest concerns.
And rightfully so. Thank you so much, Dr. Finn. This was so much information for everyone to digest.
I know,
but we're so happy that you could join us and speak about this topic today.
Well, I hope it was helpful. And again, you can share my slides. You can give everybody my email if they have any questions or want to follow up. But boy, this is just scratching the surface. My normal presentation usually goes about an hour and a half or longer.
Yes. Thank you for shortening it for us.
Oh, no worries. Thank you guys so much. You guys have a great rest of your day.
Thank you. All right, everyone. So as a reminder, the slides and the recording of this presentation will be available on our website, washtenaw.org/marijuana in the coming weeks. We would also greatly appreciate your feedback. So if you could use the link that was placed in the chat to provide our feedback survey, that would be wonderful. And as a reminder, the live webinar has been approved for 1 social work continuing education clock hour, 1 specific McBAP credit hour, and 1 credit hour of CME. If you're requesting any of these, please fill out the evaluation form with your name and email address. If you are unable to access the feedback survey through the chat, the survey link will also be emailed to all webinar attendees later today. For the next presentation in our series, Dr. Karen Oscilla will be presenting Advances in Motivational Interviewing, Practical Strategies for Empowering People to Change. That will be tomorrow at noon Eastern Time. And Dr. Oscilla's presentation has also been approved for 1 social work continuing education clock hour, 1 related McBAP credit hour, and 1 credit hour of CME. If you've not already registered for the other webinars in this series, you can do so by using the link in the chat or visiting washtenaw.org/marijuana. We hope to see you at our next webinar, and thank you so much for your participation today.